looking forward to her presentation. Nada?
Okay, thank you. Good morning, everyone. Today my talk will be about it's like a wrap-up for the risks that we might face while doing a procedure of EUS. So we have to know first what the intervention or the procedures that we are doing while doing the EUS. It's either doing fine needle aspiration or biopsies, or drainage of pseudocyst abscess, biliary or pancreatic duct access, or doing tumor ablation like radiofrequency. So the major risks that we might face, it's maybe procedure-related risks like bleeding, perforation, infection, or organ-specific risks, pancreatitis, biliary leakage, and pneumoperitoneum, or patient-related risks, sedation-related, comorbidities, coagulopathy, cardiac problems, and it's important to, before starting the EUS or any procedure, to put like a map for what the risk that you might face before starting your procedure. This is a very nice table, summarize all the risk factors that you might face while during the procedures, with different procedures and different risk factors, showing the rate of each risk factor for each procedure in the American Society guidelines in 2022. So I will go very quickly for the risk factors. If we will start with the bleeding. The main cause that we find for bleeding is either doing biopsy, or we having a very vascular tumor, or patient using anticoagulant, and the bleeding can be in either in the lumen of the GI or intraperitoneal, retroperitoneal, as we can see here in the pictures, or into the structure itself, which we are targeting, like the cyst or the organ. The symptoms, it can be presented immediately or delayed after, and the clinical significant bleeding may be shown by hypotension, dropping in hemoglobin, or having patient with hematemesis or melena. So to prevent this risk factor or the bleeding, so we have to take some precautions pre-procedural. So the multidisciplinary team decision here is very important to decide either to stop the antiplatelet or the anticoagulant or not, taking in consideration the risk of thrombotic event in some patients. Also, it's advised to use the Doppler to avoid any vessels, especially for the beginners. While doing the EUS, we have to use Doppler while doing FNA or any intervention procedures. Management, if the bleeding from FNA, FNB is self-limited and doesn't require endoscopic or interventions, or I might need endoscopic hemostasis by CLAPS, coagulation or adrenaline injection. IV fluids in severe cases and blood transfusion might be needed. Sometimes in severe uncontrolled patients, we need intervention radiology with embolization or surgery. Perforation is one of the important risk factors that we should take care, and it's usually happen with the forced push of the scope, and usually arrived with the linear, or the needle advancement aggressively while taking the biopsies. And the risk factor for this is either a trainee starting doing the procedure at the beginning, or a patient with advanced age over 65 years, patient with dysphagia or having a narrowing lumen, problem in the cervical cord, or patient with hyperextension neck. And there's sites we should take care, and with high risk of perforation, especially in the oropharynx while introducing the probe, or in the duodenum in the first part. The symptoms of the perforation, it's like subcutaneous emphysema, pneumoperitoneum, and prevention always is to take care while doing the procedure, avoid excessive force introduction of the probe, and if it happened, immediate CT scan to confirm, or nothing per oral, IV antibiotics, surgical consultation if significant perforation had happened. Small perforation may be managed conservatively, while large one might require surgery or endoscopic closure. Infection always happen. We see it with the reuse of the biopsies sometimes with contaminated, not well sterilized or cystic lesion puncture, biliary obstruction, and the symptoms is like fever, chill, or severe pain and sepsis. And prevention will be with a sterile technique should be used. Prophylactic antibiotic for cystic lesion is sometimes preferred. The management, if happened, is IV antibiotics, and the drainage of abscess is formed. Pancreatitis post EUS FNA FNB is one of the most commonly seen, or although its incidence is 1 to 3%, but it's highly seen in the pancreatic lesion especially, and the risk factor for this is multiple passes of the needle or cystic lesion, with some symptoms like epigastric pain, nausea, elevated amylase and lipase. And prevention is try to take the minimal number of passage of the needles, consider prophylactic pancreatic stents, and aggressive hydration and pain control to treat the pancreatitis. In severe case, we might need ICU care. So another one is pneumothorax and pneumomediastinum. It's happened with the fine needle aspiration in the mediastinal lesion like lung or esophageal puncture. The symptoms are chest pain, dyspnea, decrease in the breath sound, and the management is X-ray, CT for confirmation, if small observation and oxygen, if large chest tube drainage. The sedation-related complication, and this is important part for the anesthesia, like hypoxia, hypotension, or aspiration, cardiac arrest. And to prevent this, it's advised to use the ASA score that usually the anesthesia team are using to monitor and assess the patient before starting the procedure. But if it happened, the management is immediately airway support, or go to the ICU for IV fluids or vasopressors for hypertension. Rare case, but sometimes it happens for anaphylaxis from the contrast or latex allergy, and the symptoms will be like bronchospasm, hypotension, angioedema, as you can see here, with rash, treatment, epinephrine, steroids, and antihistaminics, or airway protection if severe. This is the most important part in the presentation. Still, I have 2 minutes, okay. So, this is like true or false. In EUS FNA of pancreatic lesion, the routine antibiotic prophylaxis is recommended. Okay, so it's mess. And antibiotics are not routinely needed for solid pancreatic lesion. Prophylaxis is only recommended for cystic lesion or transrectal procedures. Again, bleeding after EUS FNA is always severe. Required interventions. Okay. So most bleeding is self-limited. Only 1% of cases required endoscopic hemostasis. Risk increases with vascular tumor or anticoagulant use. We have a lot of, okay. EUS guided drainage of pancreatic pseudocyst has higher infection rates than surgical drainage. Okay. No differences in infection. When proper techniques are used, there's no difference. EUS is less invasive and preferred first line. Okay, pancreatitis after EUS FNA is rare and only happen in high-risk patient. Occur in 1 to 3% of cases, so even a low-risk patient, that we should take care of the multiple needle pass increase the risk, a central puncture increase the risk, and cystic lesions also. Okay, a tumor seeding from the FNA is a major concern. Away diagnostic benefits. Okay. Extremely rare, and the diagnostic yield is much more efficient than the theoretic risk. EUS guided, I put this because this is the important question that you are usually asked in EUS. EUS guided biliary drainage is riskier than ERCP for obstructive jaundice? No. Similar morbidity, mortality with the expert. Biliary drainage with EUS is life-saving alternative, especially when there is altered anatomy. Perforation during EUS is always immediate and obvious. No. Delayed presentation might occur, and signs like cryptus or fever and may appear hours later after the procedure, and highly suspicious when patient came with persistent pain, especially after the procedure. We should consider the perforation, taking in consideration. Using a larger needle, it increases diagnostic yield, but also major complication? Okay. No significant difference in complications between the different sizes of the needles, and yield depend more on the technique. So either you are doing suction or fanning. EUS guided interventions are too risky for trainee to perform. Hafner? Okay. No, I think it's need to be supervised. It's very important for the trainee while starting to stepwise training is safe for the patient and for the trainee. Complication rate are similar to the expert after 20 or 30 procedures. Take home message. Interventional EUS guided techniques are becoming increasingly established as an alternative to surgical, radiological, and other endoscopic approaches, and are associated with a higher side effect rates compared to the routine EUS. But I think increasing, but no, lower. Operating experience and patient selection is very important. Early recognition and protocol-driven management reduce the adverse side effect and outcomes, and it's important to have your strategy either before starting or during the procedure or after the procedure to manage any complications or risk factors that we might face. We have to very well select the patient, doing your imaging and have the history, the medical history and the imaging of the patient. Intra-procedure, Doppler is very important. Try to minimize the number of the passage of the needles. And post-procedure, the monitoring of the delayed complication is very important, and this is an important message to don't ignore the complications of the patient after the procedure. Even it's after 1 or 2 days, we should consider that might have side effects or complications. Thank you so much.